risk factors for progression in MPNs depend a lot on the genetic complexity of the disease. What I'm talking about is that we are recognizing very well that in addition to in myeloproliferative neoplasm, having one of the three mutually exclusive driver mutations, these are JAK2 V617F mutation, MPL mutation, and calreticulin mutation, that activate the JAK-STAT intracellular signaling pathway, which is common in every patient with MPN, that many patients may have additional mutations that have nothing to do with this hyperactive JAK-STAT pathway. And many may have abnormalities in chromosomes that carry genes. Now, this is much more prevalent in myelofibrosis, PV, but it is seen in occasional patients with ET and PV as well. So presence of either cytogenetic, which is chromosomal abnormality, or other non-driver mutations, which we can measure in the blood of the patients, predispose patients to a progression. This is also evident by a lack of ability to control the disease well with the standard practice medications, being interferon in PV or ruxolitinib in myelofibrosis. Genetic or cytogenetic complexity gives extra aggressiveness to that disease. There are other factors that matter. Time to intervention. Earlier intervention, for example, matters much because it's easier to manage the patients and provide optimal dosing. Case in point is ruxolitinib for myelofibrosis. Earlier intervention when patients are not so sick, perhaps also less genetically complicated, provides much more benefit, which is much more durable, and the life extension with ruxolitinib myelofibrosis is much more evident with that earlier intervention. But genetics appear to have a key role in the assessment of a risk of a progression in myeloproliferative neoplasms.